Whenever we don't have the snake ID, but we do have the syndromic envenoming lah. Okay, possibly hematotoxic. Okay, but we don't know whether it's a green pig or Malayan pig. So this hematopolyvalent comprises of three species: Russell pit viper, green pit viper, and Malayan pit viper. Whereby the neuropolyvalent comprises of Malayan crate, cobra, banded crate, and also king cobra. Okay. So for monovalent, if we do know the snake ID. So what we have cobra antivenom, NKAV, king cobra, OHAV, banded crate, Malayan pit antivenom, Russell viper, this one we do not use here lah, and green pit viper, which cover most of the Trimeresurus species. Okay. For NKAV, it can also have a cross-utilization for Naja sumatrana.
The Russell viper for Indonesia now have also.
In Indonesia, okay. Russell viper antivenom. Okay. So that's why for Naja sumatrana, if you notice, we use NKAV. Okay. Okay, this is I think one of the old one. I don't know. Indonesia. Are you still using it? Indonesian? I think we have representative from Indonesia. Do you still use this?
Sabu.
Still using. Yeah. Okay. So serum anti bisa ular.
3 different species.
Okay. Right. This one, the most expensive one that I know of so far in Malaysia, sea snake antivenom. Okay. Usually the cost now, I believe around 20k easily per vial. Okay. So usually we use 1 to 3 vials.
Indonesia also now have.
Oh, Indonesia.
We just used it 2 weeks ago.
Oh yeah, Dr. Tri Maharani. Okay. I think recently Indonesia, Dr. Tri got shared a case where patient responded very well after the antivenom and managed to extubate. Okay. Okay. So the recommended dose for the monoclate for the monovalent for Naja cotea, Naja sumatrana. So if you have systemic, then 10 vials. Okay, king cobra 10 vials. Okay, Malayan crate 5. I think just to take note that in the CPG, if you notice, Malayan pit viper, they got put 4 vials. I think it was typo, was it? It was a typing error typo lah. So supposedly the first dose should be 3 vials instead of 4. Okay. Right. For green pig, hematotoxic species usually we give in 3 trees. Okay. Sea snake usually we give 1 to 3 vials. We always start with 1 vial. Okay. Alright. So you know the antivenom. So now is the patient indicated for antivenom or not? Okay. So we divide into 2. Systemic and local envenoming. Okay, for systemic, we know some snakes, they are venomous but they are not immediate killer. Okay, for example, green pit viper, black pig. Okay, unlike those king cobra, Naja species, they are venomous. They can kill very fast, rapidly. Okay, especially if the neurotoxic envenoming. Okay, so for systemic envenoming, you watch out for hemostatic abnormalities. Usually at the first blood, the blood might be normal. Then you see the trend. The platelets start to go down and the coagulation profile start to be deranged. Okay? Even they are deranged, we see the trend. We are not just see at one particular result. But of course, we need to correlate with patient, whether is there any bleeding tendency, any significant ecchymosis, worsening swelling, etc. Okay, but having just a platelet 139, 129 doesn't mean patient is already indicated for antivenom. We have to monitor for the serial blood. Okay, neurotoxic sign, of course, the earliest sign usually is ptosis. Okay, so once patient develop ptosis, so you might want to start your antivenom. Okay, cardiovascular, look for arrhythmia, especially bradyarrhythmia, even heart block. Okay, ECG abnormality or patient in cardiovascular hemodynamic instability, persistent tachy, hypotension, right? And for those that can cause myotoxicity, So look hard for the signs of rhabdomyolysis with acute kidney failure. Okay, changes of urine color. Patient will start to have generalized muscle aching. Okay, right. Local envenoming. This is interesting and sometimes can be tricky. Okay, of course you expect after patient being bitten by a venomous snake, there should be a swelling. Okay, except for example the sea snake, they might produce a minimal local effect. But for Naja, pit vipers, okay, of course they will have extensive swelling sometimes. Okay, but whether it is indicated for antivenom right from the first encounter or not, usually we advise to see the trend. Okay, see the trend of the RPP, whether it is accelerating, is it plateauing, or is it reducing trend. Okay, okay. Just that, for example, bitten at the digits for the fingers, toes, your threshold to give antivenom should be lower. Okay. Okay, significant painful swelling over the bite of digits, toes and fingers, increasing endomonocrosis size. This is also interesting, always being a discussion point in the REX group. Sometimes you might miss the earlier appearance of the monocrosis. It become very faint, purplish color. If you do not look carefully, you might miss from the beginning. So after a few hours or few days, you see it become more clear and more demarcated. Okay? Enlarged and tender lymph node over the draining side. If you bitten over the left foot, you expected your left inguinal nerve to be enlarged, your lymph nodes. Okay? Okay, so how do you prepare? This is also will be again covered in the practical session. But just to highlight that common pitfall. Okay, we have seen people diluting each one vial into 250 or 500. So instead of, for example, you are supposed to dilute they already come with the 10 ml of water for injection. Okay, each vial. So you are supposed to dilute reconstitute the dried antivenom. So let's say you need 3 vials of Malayan pig antivenom. So supposed to be 30 ml. So that 30 ml to be added into, for adult, another 250 or 500 ml. Okay, depending of patient's fluid tolerance status. Or for pediatrics, 5 to 10 ml per kg. Meaning that if let's say the child weight about berapa? 10 kilo kan? Okay, so 10 kilo 10 kali 10 100 lah. So dilute with the 30 cc tadi. So for adult up until 500 ml. Okay, some mistake, they dilute each 10 cc into 500, 10 cc to 500, 10 cc to 500. So it give you 1.5 liter. They give 1 hour, 1 vial over 1 hour, 1 vial 1 hour, 1 vial 3 hours. Okay, that is common misunderstanding. Okay, adrenaline can be prepared, and then previous if you might read somewhere, they recommend a subcutaneous test dose. Okay, that is no longer recommended. What we recommend is actually you infuse at the slower rate for the first 10 to 15 minutes. Okay, 1 to 2 ml per minute, we give about 60 to 120 ml per hour. If there is no signs of allergic within that time, then you can increase to 500 ml per hour to complete your 500 cc over 1 hour. Okay, and then you closely observe the patients for the effect. Okay. Okay. Just to note, antivenom as for now only IV route only. Okay, local administration of antivenom over the bite site is so far ineffective, and ideally antivenom should be diluted and given as infusion. I know you might read somewhere mention that pure antivenom. There are places who practice that, but mind you, it's very high risk for allergic reactions. Okay. Contraindication, there is no contraindication for antivenom at the event of any systemic or local envenoming. Okay, even if patient develop an allergy reaction during your administration, so you can take the allergy or the anaphylaxis, then we should resume the antivenom because you need to complete the antivenom administration. Okay, sorry about the overlaps. So observation of the response do not forget to assess patient general conditions. We hope patient to be feeling better after the antivenom. Okay. Usually, if there is spontaneous systemic bleeding, should be expected to stop within 15 to 30 minutes. If there was shock, so we hope to improve within 1 hour, 30 to 60 minutes. Coagulopathy usually will be restored within 3 to 9 hours. That's why there is no role of you repeating the coag ABC immediately after antivenom, especially you give GPAV or CRAV. So you can give up till 4 to 6 hours to repeat, depending on patient condition. Neurotoxic is usually quite fast improvement, expected as early as 30 minutes to 1 hour. Okay, rhabdomyolysis within few hours. Okay, you expect your CK to come down and your urine to be improving. Okay, so there's some administration issue of the antivenoms. Whether do we need pre-medications? What are the pre-medication? Routine IV hydrocot, IV steroid, IV piriton, antihistamine. Do we really need that? Depends. If a patient already have previous history, recurrent snake bite, recurrent antivenom administration, you might want to give. But for those that first timer, there's not a must for you to give. No need. There's no role actually for prophylactic steroids or antihistamine. Okay. Dosage adult and kids are the same, except the dilution amount of volume. Endpoint of treatment, top up dose. Okay. Whether we need to repeat. If you see any persistent or recurrent coagulopathy, okay, after 3 to 6 hours after completion, you might want to consider. Sometimes it might be due to the depot effects of the antivenom or of the venoms. Or if there is persistent continuous bleeding, significant bleeding, you might want to consider. Or there is deterioration of your neuro or cardiotoxicity, okay, cardio functions. Okay, if you read the guideline before, there are holding. I mean how much quantity you want to keep at your hospitals. I think I have discussed with Dr. Zaina also before what we actually recommend for you to actually discuss with the pharmacy. I mean within your, for example, quantity maybe at your cluster area, depending on your number of cases over the year, and you come up with your projection or your estimated amount of antivenom that you need to keep. And mind you, for those that the snake does not in your so-called geolocation in your place, so you might not need to keep. For example, in Johor, to keep Malayan pit viper, I think is unnecessary. So depends on your location. Okay. So this is a guide, but I feel that I tried to calculate based on this is